All right, this is David Harsfield, currently director of the Integrative Cellular Medicine Centers of Arkansas. I serve on the board of directors for the International Cellular Medicine Society, as well as the American Association of Orthopedic Medicine. This is part one, an introduction and overview of emergency upright MRI imaging in the craniocervical junction. As an interventional radiologist, this will be my perspective on how we apply regenerative cellular therapies to these craniocervical junction issues. This is part of the Council on Upper Cervical Care Diplomate Program. This is why we leave academics and other bureaucratic endeavors. That's me in the hole doing the digging, and I've got a lot of advisors around helping me. In the real life, we all have to pitch in. None of us is as smart as all of us. So this is to be avoided. To that end, Stephen Levin taught me this several years ago. It's the fact that medical education, and even more particularly surgical training, is probably the most anti-intellectual training experience outside of military combat training. Like combat situations, in medical education, life and limb are at stake, and there's no room for learning from your mistakes, only from the mistakes of others. You're overloaded with facts, you're given little time to think, too much to do, and little time to do it in. Original thought and experimentation is extinguished and usually punished rather than rewarded. It's only afterward, after all the exams are completed, diplomas on the wall, 30 years of wasted life, practicing allopathic medicine, drug prescription, and referring to your surgical colleagues, can you actually begin to think for yourself? The wonder of it is that any of us do. So the key component here, and those of you that are in the upper cervical chiropractic diplomate program know this, don't let your schooling get in the way of your education. Now, this is basically some information that I use when there are personal injury cases for deposition purposes. The attorneys know very little of this, the patients know almost none of it, and even the chiropractors and the referring clinicians are in the dark about this anatomy around this spooky area that we call the craniocervical junction. What I do is I have this macro that I provide to all the folks that are doing depositions, and basically what we do is go through standard anatomy, and then at each particular ligament, say the tectoral membrane or the posterior longitudinal ligament or the alar ligament, at each particular ligament we show medical illustration of what the ligament looks like in real life. We show MR imaging of a normal and an abnormal, say alar ligament, and then we cut and paste the patient's alar ligament. And then that way you can compare it to whether it looks on MR like a normal or an abnormal ligament. And the guy in the back row of the jury box can easily see that this particular ligament looks a certain way. So you don't have the issues with people that don't read the craniocervical junction studies the way we do. If you just do standard T1 and T2 weighted imaging and 3 series to get them through, it's all about patient throughput. How many MRs can we get through this MR in a day? These are proton density, we'll talk about it, intermediate weighted. And it allows us to look at the ligaments and the fluids around them, not in a T1 or fat weighted sequence, and not in a T2 or water weighted sequence, but right in the middle. And that allows us to show these ligament tears. And once you know what you're looking for, it's real obvious. It's just that a lot of these folks are not trained to do this. And oftentimes these studies are read as normal. But the beauty of digital imaging is it's all stored in a PAC system, picture archiving and communication system. So it exists forever. So even if I interpreted an MR wrong 20 years ago, when I look at it now, I go, I missed that, because we still have the data that the MRI is stored in digital mode and not lost like so many x-rays. Oh, we had a chest x-ray 20 years ago, but it lost it. Well, you might have lost the film, but you still have digital information nowadays. So that's how we learn as we go. We only know as much as we know today, and that's, again, I don't have any financial constructs here. There's no, all of my research is self-funded, and I use some images, mostly my own images or from the web, And but as a human being, you have your own biases. And so what I tell folks that are listening to my talks is that these can change in a matter of weeks, but certainly year to year when I talk to the same groups. And I like to present the stuff from the year before that I presented incorrectly. I remember I used to talk about the brain has no lymphatic system. Well, turns out it does. It's not a very big lymphatic system, but it does have one. So these things evolve, and we should rejoice in that and not try to defend things that we wrote about 40 years ago, because they have to change. And we run up against folks sometimes that are having to defend something that they believe in. Surgeons think that surgery is the way to treat patients. And frankly, we're not man-made. Okay, and so as a man, I tell my patients, look, I'm not man-made. You're not man-made. I'm just a man. I can't fix you, but I can help you fix you. And with an integrative approach, with our upper cervical chiropractic care, sometimes we have to do cellular therapy injections, nutrition. We take the patient on as a whole, but we let them be in the center of the circle. In other words, patient-oriented medicine means the patient's in the center of the circle, which means the doctor has to step away. And once we start to do that and give the patients permission to heal, and we don't have this binary approach. As a medical doctor, I'm trained, it's called allopathic medicine. We spend 90% of our time on the diagnosis, and then we spend 10% of time on deciding what to do about it. And for instance, what generally happens is that we decide, okay, the patient's got X, and so what drug, what surgery? Like people are binary. There's what drug, what surgery, what surgery, what drug. People are unique. They're like little snowflakes. And the diagnosis is the most important key concept to this game. And that's why the imaging part is so important. We'll talk more here as we get into it about how to arrive at the correct diagnosis. And once that's reached, then we have alternative therapies. The patients with craniocervical junction, which is what we'll talk about mainly in these next 8 hours of lecture, has to do with the way the head sits on the spinal column. And between the skull and C2 is a vertebra, C1. It's a little ring. And in medical school, I was taught that was sort of like a spacer, a washer, when in fact, that's the fuse box of the entire human body. And if the craniocervical junction is malaligned, everything south of that, in fact, everything north of that is not going to be right. So when my patients come to me and they have back pain, certainly the headaches and neck pain, but even with back pain, they're going to go see an Atlas orthogonist to correct C1, and often that's all they need. So before we start injecting stem cells and doing all these other things that we'll talk about that are really great, 100 people come to me with a problem, 20 of them get an injection, and the other 80 we take care of without intervention in regards to a needle and so forth, and certainly no pharmaceuticals, although we may use nutraceuticals. So what we're knowing is that the whole culture of medicine right now is changing, and we call this the correction of medicine. So we can do one of two things. We can either be facilitators for the correction of medicine, or we can be party to just managing the decline of our healthcare system, which is what's been going on. And there's factors that push and pull on all these sorts of things. And truth goes through 3 phases. The first phase, I remember when Dr. Russ and I first started talking about craniocervical junction issues, and people just laughed at us. So the first phase of truth is it's ridiculed. Secondly, it's violently opposed. Once Scott and I started getting into this and showing this to other people, besides just in our silos from radiology and chiropractic, those 2 silos, it spread quickly to the all different branches of specialties of medicine. And this offends people, that it wasn't their idea, whatever the problem is, but there is a violent pushback. So first, your idea, your truth, is ridiculed. Second, it's violently opposed. Third, which is I think where we are now, it's revered as being self-evident. Meaning all these folks that were fighting us tooth and nail now see the writing on the wall, and so they come put their arms around us now and say, oh, wait a second. Yeah, no, we thought you were talking about something else. Oh, we already knew that. Yeah, we agree with you. So that's okay. None of us is as smart as all of us. It's not about who's right, it's about what's right. So the alignment of craniocervical junction is hugely important because of the problems that people have, not just headaches, but in general, neck pain and the whole musculoskeletal system. But that's the gateway for the fluid, the cerebrospinal fluid that bathes the brain, that bathes the spinal cord. You only have 120 cc's at this moment, but you make a half a liter a day. And that's got to flush through the skull and the spinal column. And the sacrum is a pump, so that when you walk and exercise, you push the cerebrospinal fluid upward. And of course, it's made into the ventricular system and bathes the brain. And it flushes out and washes out through the encephalic venous outflow tracts, the sagittal sinus, transverse, sigmoid, and jugulars. There are little drains along the way, pachyonian granulations, and the CSF sneaks out of the brain, and it's already washed all the amyloid and tau proteins, the metabolic products from the brain tissue. The problem is when the CSF can't get through, can't flush the brain, then you get buildup of these products, these so-called tau and amyloid. They're not bad actors, they're natural metabolites. In fact, some folks, and we'll talk about that in another lecture, it may be in reaction to an infection of a germ, a virus, or a bacteria. And this amyloid is part of your brain's immune system trying to fight off an infection. But if we don't have the CSF to flush it out, then it builds up. And in 30 years, that's Alzheimer's. And we know that on the space station, when they're in microgravity, because the encephalic venous outflow tract is valveless, that the cerebrospinal fluid gets backed up as well. So when you don't have an up and down like you do on Earth, you don't drain the venous flow out of the brain. The heart pumps the blood in, but it can't get out. And neither then can the cerebrospinal fluid. And over time, you get increased intracranial pressure. And it might only be a couple of weeks to 30 days on the space station, you've got increased intracranial pressure. And it pushes on the eyeballs, flattens them. They have visual problems. It pushes on the pituitary gland. A lot of things happen in 30 days in low Earth orbit that would take 30 years on Earth to occur. So we're learning a lot of things about our collaboration with what's going on in microgravity with NASA. And we're applying that to health and well-being on Earth. And a lot of the stuff that's happened on Earth, cell phones, look at all this stuff. All that stuff came from space travel. And the reason is it's expensive for heavy stuff to go into space. Yeah, believe me, if you remember the radio or the TV in your grandmother's living room, how heavy that was. Well, that's expensive to fire that off the ground and put it on the space station. That's when we have these little cell phones that are the size and weight that they are. All of that comes directly from our travels. And so NASA is a very important part of mankind and what we do beyond the 70 or 80 years that we're on this planet. So in working with them, we've learned that there's a lot of mechanical issues at the craniocervical junction, malalignment, things that can be measured. But beyond the structural, static anatomy, there's abnormal motion, pathokinesiology. And that's why flexion extension views, the digital motion x-ray, watching the patient walk across the waiting room. You can tell more about that patient than I can with 100 MRIs taken when he was laying down on a recumbent MRI table, and we tell him, don't breathe, don't move. We're not going to find the anatomy that we need doing recumbent, non-weight-bearing static imaging. We've got to do upright weight-bearing motion imaging. We do have upright MRIs, there's not a lot of them, but there's some around the country. And then you can do fluoroscopy, and then the other thing is that the chiropractic community is so good at is hands-on and physical diagnosis. People talk about doing certain things in medicine and healthcare is changing, and you see people that are getting in trouble because they're trying to cut edges and whatnot. Here's what I tell my residents. Tell a story that ends with, anyway, that's how I lost my license to practice medicine. And I make them all sit and tell me a story of something that they wouldn't do, but something that they might have done that would cost them their medical license. We've got to think that way. We can't take shortcuts and do things for any other reason than what's the best thing for the patient. Now, how does radiology get into the correction medicine? If you think about it, radiologists for years, until now with interventional radiology, and we're actually doing the stem cell injections and so forth, but for years, radiologists basically worked in a dark room. Now, in the old days, it was pretty much the doctor's lounge of the hospital. So everyone came in and commiserated and looked at their x-rays together. Well, now it's too busy. In the old days, I was reading maybe 10, 12,000 exams a year, and I was giving lectures almost every day and writing papers in academics. Well, you go into private practice, and we're reading 25 to 35,000 studies a year. And the old head CTs used to be about 8 slices from top vertex to the bottom base of the skull. They could be 250 slices or more. There's so much more volume now. The radiologists are pushed back further and further into that dark room. Problem is, they need to get out of that dark room, and the patients need to know who they are, as do their physicians, because basically we were the lifelike monitors. I don't know if you've seen the advertisements of these folks that are standing in a bank robbery, all dressed in a policeman's suit, and the bank robber is getting robbed, and people laying on the floor going, "Hey, aren't you going to do anything?" And it's a lifelike monitor. He goes, "No, I'm just monitoring. I just, by the way, there's a bank robbery. I'm going to go play golf." Well, radiologists were lifelike monitors. We'd see a nodule somewhere, and the doctor or patient say, "What do you do?" I say, "I don't know. I'm going to refer you out." So instead of, we were mainly in charge of de-scription, describing things. And now we are going to be leaders in prescription, prescribing treatments for certain findings. In other words, we're going to be able to fix the problems that we find, and not just point at something on a chest film and then have no alternative but to refer to another doc. Or if you see something that's at the craniocervical junction that not many people understand as well as you do, and you know how to treat that, then you work with your chiropractic colleague to realign C1 in the craniocervical junction. And if it doesn't stay aligned, then you have to do injection of cell therapies. Much like if you tore a cruciate ligament in your knee, you'd have to inject cells into the knee to heal the cruciate ligament. That's the static stabilizer. And then you got to train the muscles around the dynamic stabilizers, the quads in the front and hamstrings in the back. You have another cross-shaped ligament at the C1-2, and it's the cruciform ligament. And when you tear that, that's the most mobile joint in the human body. It moves 600 times an hour, even when you're asleep. If you've got a cruciform ligament tear, it's like having a cruciate ligament tear in your knee. You're going to wear that joint out. The problem is when that joint, C1-2, wears out, it hypertrophies and enlarges. It closes off the space for the CSF to get out of your skull and to get into your body. So what we're doing with diagnostic techniques with MR and so forth and kinematic studies as radiologists is we're working with our chiropractic colleagues to help with the diagnosis. And when needed, we can do injection therapy to heal the ligaments and also do pain injections around the neck for pain control. So we're not just de-scription, we are prescription in our responsibilities. Now here's the other thing. We have these things called informed consent, where you hand this to the patient and you start talking real fast, so you don't understand anything you're saying, and he signs at the bottom of the page. That is an uninformed consent is what that is. And we have to stop that. We have got to let the patient know what's going on and what's the diagnosis and what we think potential therapies are, including continuing doing this. And surgery and drugs are not necessarily the alternative. Regenerative and cellular medicine is the way we're going to heal each other in the future. Now, one of the things that we do now, it can be difficult to know the right thing to do. I mean, that changes from time to time. There was a time when you scope every knee that came in. Now we realize 90% of people who get a knee scope for a knee injury are no better in 6 months than those that didn't. They were handled conservatively. There are a lot of things that we can do that are great for acute issues, but most of the problems that humans have now are chronic problems, or aging even, which is not a disease, but it's a chronic issue. We can't keep throwing acute solutions at chronic problems. So the right thing to do changes, and we need to stay on top of that. What we are recommending now, the right thing, are these regenerative and cellular therapies. And there have never been a significant serious adverse events associated with injecting someone with their own stem cells and having them undergo proper chiropractic care. The worst thing that happens, it doesn't work, which is, it's not good, but it just means that that's not our fault. We had the wrong diagnosis. But we don't do things that make people worse. A third of the people that get a total knee replacement never go back to work. The patients, we do stem cell injections for their knee arthritis and pain, are out playing golf in 6 months. So these regenerative therapies, when added, combined to a craniocervical junction practitioner, are going to be enormously important, because one of the things coming down the pike is neurodegenerative problems, Alzheimer's being the big deal, but Parkinson's and all that. All that has, every one of those processes can be made better, and certainly worse, relative to the cerebrospinal fluid homeostasis. And that's the cork in the bottle at the skull base right there. And that's what we're going to talk about in these lectures. The other thing too is at some point in time, you have to, in your career, begin to acknowledge your ideals. Your ideals, you're educated. You know what the right things to do is, or that you don't necessarily have to do what your chairman or your boss says just because he said it. And when you're going to step out and do things this way, when you've done things that no one else has done before, you're not going to have mentors. No one's ever done this. So you have to have strength in your convictions. You got a great community and collegial relationship here. We're learning a lot of great things about how the brain works. And here's another thing we're learning, very interesting. The spinal cord is not just a connector between the brain and the extremities. It's its own man, or it's its own entity. We are now, in people with high cord transections, not getting the cord to talk, but we are training the cord without the benefit of the brain being connected, and people are moving their limbs. And so we're doing some really great stuff. But again, if you're doing upper cervical chiropractic, you are on the pioneer of medicine. And as we said, either we're going to be facilitators of the correction of medicine, or we're going to be relegated to just being managers of the decline of a healthcare system. Now, patient and family-centered integrative medicine sounds like a Hallmark card, but there's actually a fellowship in patient and family-centered integrative medicine. Basically, the concept, and we're building centers now around the country, you have large facilities that are kind of open air facilities with a walking track in the center for people to exercise and walk, limp, most of our folks, and maybe some exercise equipment in the center of the circle. Around the periphery of the circle, again, these are great big open air facilities, are the doctor's offices. Around the periphery, there's a podiatrist there, there's a chiropractor there, I'm an interventional radiologist over there, a nutritionist, and so forth. And so that the patients have access to all of these services. But basically what patients do is this is a place to go in their community that's not the hospital. And what's happened in the past is everyone that had any sort of ache or pain or any issue went to the hospital. And they just don't need to do that. Some people are, that'll make them worse. And so by the hospital and the community will take care of the acute illnesses and so forth. But most of the problems we have are intermittent, low grade, or just chronic problems, mostly dealing with pain. And when we build these patient and family-centered integrative medical clinics around the countries, within 6 months, the women run them. The matriarch of the family makes all the healthcare decisions. And so she's going to be in charge of making sure Uncle Ed, whose knee hurts, quits smoking, loses weight, does his exercise much better than we can. And we bring their whole family in when Uncle Ed comes in with a sore knee, for instance. His whole family's in a room with us. And so I go, okay, you've got a left knee problem. Talk to me about what's been going on. And in the history, you find out he sprained his right ankle 6 months ago. And because of his altered gait, that's why his left knee is hurting. So the left knee is a symptom. The right ankle is the diagnosis. But even more than that, we tell folks, we're going to help you get rid of your knee pain, but look at you. You're overweight, you're smoking, we're going to help give your health back. We're going to give you the instruction manual to your body. And again, it's hard for folks. They're confused. Everything they see on television. Buy this food, drink coffee, it makes you live longer. Oops, next week, coffee kills you. Next week, drink wine or don't drink. We have a narrative now, and by the way, it changes, but it has to do with nutraceuticals, the proper nutrition. Sometimes when patients come in, their immune system, which lives in your gut, 80% of your immunity resides in your GI tract. It's sick, and when the gut's inflamed, it's leaky, so you can't eat your way back to health. And so what we end up doing is, with IV therapies, seal the gut, Then we get them back on a nutritional dietary plan with some nutraceuticals. There's a lot of things missing in the soil now that was there a century ago. I mean, you'd have to eat 20 apples today to get the same nourishment of one apple in 1964. So we're going to have to do nutraceuticals. The key is we don't need to do pharmaceuticals. We don't need to do opioids and narcotics because that just sweeps the problem under the carpet. We got to fix the problem. And non-steroidals, ibuprofen and Aleve, are killing our kidneys. Look at our dialysis rate in the country. And so trying to get people off of pharmaceuticals toward nutraceuticals, they need an environment. It's too hard for them just to come to your office and listen to you and then go out into the world that's shooting advertisements from TV all day, all night to tell them to do other things. And physicians sometimes don't understand this. So this is the integrative medicine approach. And so it's like building these Noah's Arks of doctors, 2 of everything. You don't need 52 of me, you need 2 of me, and 2 Dr. Rosas, and 2 Julie Mayer Hunts, and 2 of you. And when we work together, then the ladies in the community, and you go into the communities when you build these, and you talk to the churches and the community groups and leaders and so forth, and you build the centers, and they own it, and they run it, and they tell us how to do things that we may not be doing correctly. They may say, we need to have a program on a certain concept here. People know how to cook the Mediterranean diet. You keep to tell us to eat this thing. How do you do it? I go, well, it's tricky. It's not as easy as you would think. So we have cooking classes. But I'm saying upper cervical care, if we don't fix that, then we're going to have a bunch of 1 in 3 people with Alzheimer's. And we don't have enough caretakers and healthcare providers to take care of this tsunami. I believe that upper cervical care, in conjunction with regenerative and cellular therapies, can address that, can slow this down, can identify the cause. And there are really some interesting things going on now. We're moving away from the pharmaceuticals and trying to just sweep things under the carpet. We're figuring out what it is. And believe me, cerebrospinal fluid flow is a key. If it's blocked, that patient's not going to do well. If it's unblocked, it's amazing how fast this can relieve a lot of neurological problems. So in our patient family-centered clinics, we have 6 steps in our guidelines. 6 steps, and the 6th one is a patient registry. So let's just forget about that for a minute. Number 5 is us, is me anyway. So the patient's got to go through the first 4 steps, 1 through 4, before they get to see me. Because I'm going to be able to, when I finally see the patient, they're not just going to walk in with a limp and they have knee pain and I shoot something in their knee. We're going to do better than that. First thing we're going to do is call the patient's primary care provider because he's got the electronic medical record. He or she, I should say. We're going to try to find out what is the proper diagnosis. Okay, the patient's got tons of history, and here's a primary care doc seeing 130 patients a day. He hadn't got time to do anything. And so I just like to call him personally and say, hey, this is Dr. Harsfield. Oh, yeah, Dave, heard you were doing a regenerative care project in the state of Arkansas. Yeah, we're the first state in the United States that are going to actually be able to pay for these stem cell therapies for patients. So instead of having a total knee that costs $60,000, you can have a stem cell injection on your knee with proper chiropractic care and nutrition and so forth, all of that for $10,000. And you're actually better. And so that's what's going on in the world. It's just starting in Arkansas for whatever reason. This is our home state. So the primary care doc goes, I want to learn about that. It's okay, you got 1 million patients, but on the weekend we'll give courses. You come by and let me teach you how to not inject steroids into that shoulder and instead inject cell therapies like stem cells and platelet-rich plasma. So number 2, once the primary care guy says, I got to go, fine. So now our group is working on the electronic medical record, looking at Uncle Ed's history, blood pressure, all this sort of past, all this information that if he had a thyroidectomy 20 years ago and forgot to tell us, that matters. So we got to start working through the existing history and then coordinate with the patient's chiropractor or manual therapist. Now we're talking physical diagnosis. So we're going to get past history. We're going to have chiropractic physician or physical therapist to start working with Uncle Ed and figuring out what's going on physically with him. Number 3 in the guidelines, after we're gathering up all the healthcare records, is we're also going to look at blood work. We're going to take a panel of about 25 things that we need to measure. Selenium, for instance, it's very low in the soil nowadays, and it's a key component for noisy joints. If a patient has a creaky, noisy joint, he probably has a selenium deficiency. So patients can have sore knees from torn ligaments or loose ligaments, but they can also have it from tight ligaments. Selenium is a tightening issue, and you can put them on selenium supplementation in a month or so, their knee's quiet and it doesn't hurt. So number 1, call the primary care doc. Number 2, start working with our chiropractic colleagues. Number 3, we get all the appropriate surgical and medical history and start looking at the patient's blood work, and we might have to look at his gut microbiome. And when we find out that he's got inflammation of the gut, we have to use IV fluids to get the fire in the GI tract out, and we have to do that with IV nutrition. And what's in those little bags is based on the patient's lab work. So this is perfectly synchronous with the proper way to work a patient up. And rather than just treat each symptom as an isolated event, Uncle Ed's knee, what am I going to do? Throw some NSAIDs at him. He already had hypertension and renal failure, and the NSAIDs tipped him over. This is the kind of thing we do without thinking. And again, hypertension, there's another concept that we are so missing the boat. Why are you going to a cardiologist or a heart surgeon for high blood pressure? Your kidneys are in charge of your blood pressure. Those guys take care of the pump and the plumbing. The blood pressure problem is from renal disease. So there's your IV nutrition and so forth. And once we've evaluated your lab work, got your IV up and going, you got 2, 3, 4 weeks into that, you start to feel better. 100 people come to us with a sore knee, we inject 20 of them. The other 80, by going through our 6-step guidelines, are taken care of. And who knows what it was, a leg length discrepancy, pelvis was tilted. It's almost always craniocervical junction maladjustment. Once you straighten that up, everything south of that realigns. It's pretty amazing. And it's safe, it's very inexpensive. Then finally, number 4 is make sure that we got enough imaging studies. And as a radiologist, I don't need a lot of these imaging studies. We way over image, particularly with X-ray. We got to remember those X-rays are dangerous. That's ionizing radiation. And if you don't need a CT, don't get one. And if you want to use MR, that's fine. You don't need IV contrast with it. That gadolinium is toxic. We can get a lot of the information we need by hands-on clinical exam, especially the chiropractic and manual therapy community. But then occasionally you do need an MR to look at things that are maybe not even spinal related. And we'll talk about in another talk extra spinal abnormalities, because there's a lot of things that can give you low back pain or neck pain besides disc problems. And you look in the field of view in a cervical spine area and you see a tumor of the thyroid or an aneurysm of a vessel that's causing symptoms. So when we do imaging, and it's spinal imaging, like a C-spine or T-spine or L-spine, we look at the entire periphery, and it's on source images the technologists use to set the scan up. And they're available. You just need to make sure that when you sneak over and look at them, you'll be doing a lumbar or abdominal study, and at the very lower edge of the film, you see a lung cancer. Bingo. So there's a lot of extra spinal findings. And in the craniocervical junction, it's so busy, and we'll get into that, that you don't want to miss any little subtle findings, because if you think about it, all basically we look for, particularly in personal injury and after trauma in the cervical spine, is a fracture or a herniated disc. And rarely are those going to be present. And even when they are, they're not the cause of the patient's symptoms. The problem, if you think about it, there's only 5 discs in the cervical spine. Of the 7 segments, there's 5 discs. Well, what happens between the skull base, C1 and C2? There are no discs there. That's a beautiful suspension of ligaments, the static stabilizers, the cruciform, the alars, accessory. It's awesome, unless they're torn, and then you have instability. And now you got to try to balance this 12-pound bowling ball that we call our head on top of your cervical spine, and there's nothing holding it up. So life is about balancing that bowling ball. And if you sit with your head down when you're texting, instead of your bowling ball weighing 12 pounds, it's the equivalent of a 60-pound bowling ball. So you wonder why your trapezius and your neck muscles hurt when you've been looking at your cell phone and texting all day or sitting at your desk funny. All these things that we are talking about doing with our 6 guidelines include very little pharmaceuticals and very little surgery. They include things like, well, Uncle Ed, you're dehydrated. Drink water. Or Uncle Ed, you're a truck driver for the Walmart, and that's why your knee hurts, and you're sitting all day long. And if we can't change your job, we're going to have to get you to doing some proper exercises. So drink water, exercise. You need more sleep, Ed. You can't be getting 3 hours of sleep a night. You need 6 to 8. Kind of an argument now, fist fight almost, about how much we need or don't need. We need more sleep. Oh, and then you need to quit eating fast food and start eating some normal food, which is no more, probably less expensive than eating out all the time. And so if you just think about what we just asked Uncle Ed to do, it didn't cost anything. Drink water, get more sleep, get some exercise appropriately, and eat the proper kind of food. That didn't cost anything. And then if you have some deficiencies, we'll address those with IV nutrition to close your gut if you've got an inflamed gut. And then when you need some sort of selenium, magnesium, cadmium, those things, we'll put them in a little IV bag and give them to you. 2 IVs a week. Next thing you know, your gut's not inflamed and your cholesterol level drops, which, by the way, the cholesterol is not an evil creature that you have to take a statin for. That is totally misunderstood and been misrepresented for obvious reasons. Cholesterol is an insulator. And when you have a fire in your house, it's usually in the kitchen. Well, when you have a fire in your body, the kitchen is the gut. And when the gut's on fire, the cholesterol level's high. And the bigger the cholesterol molecule, the better. You don't want the little bitty ones because they get into the interstices and crevices of the vessels. You want these great big beach ball cholesterols rolling down the vascular system. And once we put the fire out in your gut for GI, leaky gut, and so forth, your cholesterol drops. So all this taking statins, we've got to quit doing these things the pharmaceutical industries want us to do. Nutraceuticals, drink water, exercise, eat the right food. I mean, it's that simple. It's just you have to provide the patient narrative. And like I said, within 6 months of having these clinics on the ground and open, the women run the clinics. It's the coolest thing that you've ever seen. In fact, when I was a kid, my mom stayed home, and the only 2 jobs that women could get in those days were as a teacher and a nurse. We had the most powerful society that I can remember in the United States. Mom was either home, or she was our nurse, or she was our teacher. So how about if we put her back into control? Take the matriarch of the family, put her back into control of these patient and family-centered healthcare programs, and then that's when upper cervical chiropractic and cell therapy that seem so crazy to the existing medical practice don't seem crazy at all to Mom, because they work, and she knows they work. So again, the 6 guidelines that we use on this approach: primary care doc, notify him first because he owns the patient. And then the chiropractor is the second person to see the patient. Often adjustment with that, 50% of the people are gone. By looking at the primary care doctor's lab work, we take them off statins and all these drugs that they don't need. And then you get their upper cervical alignment and get them on the right exercise program, hydration, sleep, out of here. And by the way, knee pain was something that just they thought about, don't think about it anymore. So primary care doc, chiropractor, you correlate all their lab work and give them IV therapy if you need. Do imaging if you need it, generally don't. And number 5, finally they sit down with me and I've got all this data. And I'm looking at Uncle Ed and I go, okay, here's what's going on. And how are you doing? He goes, I'm doing pretty good. My knee still hurts, but I feel a lot better. You know, I'm moving out of that, driving that tractor trailer rig, and I'm going to move into another area in the Walmart Corporation so I can walk more and get out of that truck. So, oh, good. Okay, so you're changing your lifestyle. That's awesome. We gave him permission, but you know why? Who gave him permission? His wife, when she heard the instructions. And so I sit and talk to Ed, but his whole family's there. And I tell him, I said, this is what we found. And you're feeling better. You're doing great. What would you like to do from here? Including nothing. Keep doing what you're doing. He goes, well, I thought you were going to inject me with some stem cells. I go, well, I could do that, but you may not need it. I'll just let you decide. And they look at me like, what? I decided, and I look at the patient. You get 51% of the vote. Okay? So I'll do what you want me to do. This is what my diagnosis is based on all the findings from all the docs that we know. Here's the therapy that you're undergoing. You're doing well. You're not perfect. If you need an injection, we can do that. But if you don't, keep going. You may be fine without it. Your call. And the patient's now in control. And that's what we want, is we want to allow the patient to be in the center of the circle. And when they get better, they call us and thank you so much. I go, we didn't do anything. You did this. You quit smoking. You lost weight. You changed your job. You did all these sorts of things. And then you trusted this chiropractor to adjust C1. That's hard to do now if you don't understand. And you've always been told you need surgery or a drug. So the beauty is patient education, but I'll tell you who's in charge of that, the matriarch of the family. So the sooner mom understands what we're doing, the better. And the stuff that we do is very safe. Now for what to do and how to do the protocols, that's what I'm going to talk about. Now these are guidelines here. This is just how to work the patient up. The dignity of a proper diagnosis is very powerful, particularly people who've had headaches and neck pain and fibromyalgia, and doctors push them away and tell them they're crazy and it's all in their head. When they come to us and we can explain to them, it is all in your head, but it's real. And it's the alignment of these vertebrae, the craniocervical junction, and that we can realign that. And if it doesn't stay realigned, then we can inject it with cell therapy like you do for a torn cruciate ligament. And that you're going to have to get your gut well because you can't heal without an immune system. So we're addressing the entire issue. And when the patient gets better, we tell them, you congratulate yourself. It's very empowering to be able to heal yourself. I think that's what the Lord intended anyway. So having said that, what we'll do is, again, these are not standards now. These 6 guidelines, they're fuzzy little things, and they may change a little bit. Clinical guidelines provide research-based information, but they're flexible. And standards are rigid. You know, doctors, well, no one likes being told what to do. So these are kind of soft if-then charts. If this happens, then do that. If that's the result, then do this. So the if-then charts are what we try to come up with. But again, it's not rigid like a standard. We're not declaring that everyone has to do it. The fact that we have a patient registry, it's going to prove that what we're doing works. That's powerful. So the literature out there about steroid injections has been out there forever. They don't work. They make people sick. The way steroid injection works, steroids are crystalline, Kinlog or crystalline, and they like each other, so they make snowballs. And you inject them into an inflamed area, it infarcts everything like emboli. It kills the nerve and all the tissue around it. Well, the nerve restores and regenerates within 4 to 6 weeks. It's pretty resilient. But the tissue around is turned to mush. 2 or 3 steroid injections, there's nothing there. The tendon's mush, the collagen, so forth, dissolved. So all the concepts of the standards are epidural steroids have got to change. And so what we're saying, these are guidelines. There's no sense in knocking heads with people if you don't need to. These are guidelines, and this is how we run, and this is our registry that shows how this stuff works. And oh, by the way, through the patient registry, we found out that a lot of people that were on non-steroidal anti-inflammatories, the NSAIDs, a lot of those folks weren't getting better. And we did a little research, and within a month figured out NSAIDs inhibit the good regenerative inflammation. So you're never going to heal. It stops pain, but you'll never have the regenerative inflammation you need to heal your body. What you've got is degenerative inflammation going on. So with our therapies, we are instituting regenerative properties to the body, beginning with the immune system, IV therapies, and so forth. But if you don't fix the craniocervical junction, your brain's not going to be right. And that's the center of the universe. So if your brain can't talk to you and tell you what to do and feel okay, these poor people with headaches and neck pain just are pushed from doctor to doctor. In fact, on average, I think there's about 9 doctors that patients go through before they find one of us that understand what's going on with them. I remember the Journal of American Medical Association, 2009, the January 14th issue, the Chiari conundrum is what they called it. So people that have blockage of CSF at the craniocervical junction, it was a conundrum. Dr. Rebecca Volker was the doc that writes about these. things, but you go back and look at that JAMA article, it was the beginning of, hey, these people, there's something wrong here. We don't know what the deal is, this Chiari business. Maybe we didn't understand it, but we're going to have to, because these folks are being made well by folks like Dr. Scott Rosa, who are adjusting C1 and changing CSF dynamics, and suddenly their headaches and dizziness and crazy symptoms that didn't make any sense to us are being corrected. So here's the problem. There's not enough Scott Rosas. And that's what those of you who are watching these lecture series are all about. So we're going to be available to you, I will be personally, to help you with imaging studies that you have questions about, or how to acquire them or interpret them. But the bottom line is proper diagnosis. Let's figure out if the craniocervical junction is malaligned. What's the fallout? Because each person has a different ability to cope with a craniocervical junction dysfunction. When the CSF gets stuck in the head over time, it increases the pressure, just like on the space station in microgravity. The CSF slowly builds up, but it's a uniform increased intracranial pressure. So it basically decompresses into the optic sheaths and flattens the eyeball. So now they have visual issues. And it also, the increased CSF pressure squeezes on the pituitary gland and gives them partial Sella syndrome, they call it. But that's a generalized increase in intracranial pressure. If we can readjust C1, we can improve that. Now here's the other thing happens in space because of the microgravity. It's not zero, it's microgravity. The spinal column, all the curvatures in the spinal column gone. So the spinal column's too tall. And the spinal cord is attached by the dentate ligaments at each segment, and it terminates generally around the thoracolumbar junction. But the dentate ligaments are tough little ligaments, and they tug on the spinal cord, and they pull the brain, namely the cerebellum, down into the foramen magnum, creating a cork in the bottom of the bottle there. And so each time your heart beats and systolic pulse enters the brain enlarges briefly. And when that happens, the cerebrospinal fluid that's floating around in there is pushed south through the foramen magnum. And during diastole, it's pulled back north. So the cerebrospinal fluid pulses almost in conjunction with your heart, but also related to positioning and inspiration and Valsalva and things like that, respiratory change. But basically, if your CSF can't travel through the foramen magnum, you got trouble. And so these folks, when they come home, are very tall. Their spinal columns are too straight, and they've got a cork in the bottle. So if we can recapture the curvature of the spine, particularly the cervical lordosis, it releases the spinal cord so the brain can float back up and away from the foramen magnum. And that's what Dr. Rosa does. You can see it almost instantly from a very straightened cervical spine to lordotic curvature return. And then we've got some really cool studies. I'll show you where the CSF, we can watch it move like you'd watch blood flow in a carotid Doppler. And you see CSF movement in time. And then when Dr. Rosa is at the Research and Development Center in Latham, New York, he does a pre-adjustment evaluation of the brain and structure, but also CSF movement. He has them come off the MRI table, adjust them, their C1, puts them back on the table, and we repeat the study. It's amazing how fast the changes occur. So if you can utilize these guidelines in your practice, and it'll help you so that you're not, alone in the desert for 40 years or however that story goes. We've all been there. But what's, I think, brought us back now is that all these silos of medicine are desperately looking for a way to take care of Alzheimer's. That's the tsunami that's coming. Diabetes, which is diabetes with obesity, is right behind it. That has to do with the gut. We're going to treat everything together, all 11 systems of the body, even though we're going to concentrate on the musculoskeletal system and the central nervous system, because that's kind of what we think about at the craniocervical junction. All 11 systems are listening to what we do. So even though we're kind of treating MR imaging findings of the bones and ligaments and muscle and so forth around the neck, we're going to be interested also in the cerebrospinal fluid, metabolism, endocrine issues, and so forth. So the key to this, now that we finally understood how adjusting C1 can be so important, I mean, you can change blood pressure. The group in Chicago changed blood pressure, systolic and diastolic, by 17 millimeters mercury. That's like 2 drugs. Just by having a cervical adjustment, you can lower patients' blood pressure. So once we start doing these things, we need a patient registry. That's the key, so you can document that what you do is real. Because like the guy said, if you're not writing it down and you're doing experimentation, you're not writing it down, you're just messing around. So we got to write it down, and we're going to do that. This basically talks about, here's little Stu. He's hiding behind a door over there. He's playing a little trick on the radiation, the X-ray technologist. He put a bag of ashes on the table, and she's thinking she just scorched him. The humor here is not as funny as initially. These X-rays have a lot of radiation consequences when you think about them. We need them, fine, but if we don't, we don't. And in fact, there's a lot of imaging going on that creates trouble for the patient, that finds these incidental findings that then have to be tracked down. And the patient ends up getting surgeries or biopsies and stuff that they didn't need because of something that incidentally showed up. So we're trying with MRI of the spine, for instance, the insurance companies are saying, hey, these MRIs don't correlate at all. They don't help the patient at all. What we're saying is recumbent, non-weight bearing, static MR doesn't help much. Kinematic or pathokinesiology, those abnormal findings are extremely helpful, but you got to have an upright MR, or you have to have a fluoroscopic unit where the patient's upright and able to move. But a good chiropractor and a manual therapist can feel and do clinical evaluation until there's an instability. And the two key findings are instability and rigidity, not disc herniation, not bone spur, not any of that stuff. The two key findings are, is the segment unstable or is it rigid? And frankly, rigid segments that don't move appropriately actually create more pain. Usually when you have a rigid segment, say C5-6 doesn't move well, C4-5, the next door neighbor, is hypermobile. And a lot of times with high velocity chiropractic, you're just moving around the one that's hypermobile. You're not really creating motion at the rigid segment. That was the culprit. But by doing these kinematic studies, upright imaging and so forth, you're going to see a whole lot more important data. So we're trying to say, don't not do MR. Just try to do more kinematic MR. Or even if you're doing recumbent, now that we know what to look for, we can see the indirect evidence of these instabilities by looking at end plate changes and things like that at a hypermobile disc, or by looking at partial ankylosis at a static disc. So you don't necessarily have to have an upright MR, but it's nice to have. The thing we don't want to do is over image and then send this patient off to get surgery they don't need. Now, this has to do with a study out of Canada that looked at the sorts of things that cause the most trauma to the brain, because we're going to talk about traumatic brain injury during the course of these 8 lectures. If you remember, those of us that played football, this is how the coach taught you to hit the guy you were tackling with your forehead. Now, you got a helmet on, hopefully. You didn't play in the days with no face mask like my dad. But what you want to do is contact your forehead with their chest. And this provides the least amount of angular acceleration. This is represented by the graph here. This is time here. Position number 1 gives you very little angular acceleration when the contact drives this direction. Number 2, when you get hit in the chin and it drives vertically, this is the most severe injury as far as angular acceleration. Now, when your head's leaning back and you're struck in the chin is a little less stress, but again, number 3 shows both of these head positions here with the strike and the angle of the mandible create the most angular acceleration, therefore the highest probability for traumatic encephalopathy. So we're trying to teach kids to tackle this way. On the other hand, if you're hitting something with your head, even if you're just heading a soccer ball, you're doing damage to your little brain. I mean, this is the facts of life. when the head is forced back by impact, you can also fracture the C2 vertebra, the so-called hangman's fracture, and you can get cord damage from that. This is the craniocervical junction here. There's a lot of anatomy here. And by the way, you can go through these slides and you can freeze them and go through this anatomy at your own leisure. These are Netter slides, and Frank Netter is awesome, but Ron Tribble is our medical illustrationist that does it in 3D with a relief. You're not going to believe the medical illustrations we have of the craniocervical junction. These are a little bleak. I mean, they're very accurate, by the way, but just a little bit busy as opposed to the illustrations that Ron does, and you'll see them throughout our lecture series. Let's talk a little about just the overall contour of the skull, the frontal, parietal, and occipital bones, and then the temporal bone is here. This temporal bone tends to be the one that rotates the most. There's a group of physicians called craniopaths. And when you sleep a certain way, or maybe from trauma, your skull, these little bones, because the sutures are not fused, even in an adult. The coronal suture here is C-shaped. The lambdoidal suture back here is L-shaped, the one at the occipital and parietal junction. Here, the temporal bone, because of the stress when we sleep, can push this and rotate it. Well, the seventh nerve has to travel through here and can be stretched, and people can have what they think is a Meniere's disease or seventh nerve palsy, and they change the position of the temporal bone, and within 20 minutes, their paralysis is gone. So much like a cranial nerve can be entrapped in its pathway from the brain to its end organ, much the same way a somatic peripheral nerve can be entrapped by disc herniation, for instance. And then the zygomatic bone, of course, and the nasal and the maxilla, and then the mandible here. Again, this is a very basic anatomy. Posteriorly, notice the L-shaped lambdoidal suture between the occipital and parietal bone. Of course, the sagittal suture goes dead down the middle, and the coronal sutures up front makes a C shape. And then now we're looking at pterygoids, medial and lateral pterygoids in here. And here's your occipital condyles. These are the little guys that sit on top of C1's shoulders. And the CO, we call this the C0, sits on top of C1. And it's the beginning of the craniocervical junction. So it's C0, C1, C2, that's our CCJ. Of course, we can kind of look at it through the wrong end of the telescope and kind of minimize it if we want. We got to recognize that this is important anatomy. We're going to wade off into it in the next lecture series or so. We're almost done here. But we can't take it out in isolation. This is the fuse box of the human body, we believe, because not only is the CSF has to sneak through this passageway with the spinal cord and vertebral arteries in the way, but also a lot of the cranial nerves have got to travel this way. So when this is malaligned, we have issues. And internally, this is where we see the crista galli. This is where the nerve for the olfactory system lives, and it's really more part of the central nervous system. Like the optic nerve and globe are really central nervous system. They're not really a cranial nerve. They're an extension of the brain. Well, the olfactory is the same way, and your brain sits on this cribriform plate. When you breathe things in through your nose, that's why they're doing intranasal drug delivery. You breathe something through your nasal aperture, and within 20 minutes, it's in your cerebrospinal fluid. Who knew? So that's how you can get across the blood-brain barrier, is just breathe it, which means if you're breathing good stuff, great, but if you're breathing toxins, like is in our environment, you're going to get a lot of toxins in your brain. And that's through this cribriform plate. And then here's where the pituitary gland lives here. And then here's our foramen magnum, and that is a narrow little spot when you got to move 500 cc's of CSF a day through it. Okay, we'll talk a little bit more in the next lecture about traumatic brain encephalopathy, some of the clinical practice guidelines, again, if-then charts. Thank you for your attendance, and I'm available. I'll make my contact information available to you folks.